Thank you, Charles, for the introduction, and very good evening to my Asian friends, good afternoon to European friends, and a good morning to the friends from Americas. I'd like to thank Chinese Society and Panther Healthcare for giving me this opportunity. And I'm going to talk about the management of, how to minimize the risk of COVID-19 infection among bariatric surgeons and bariatric patients. And I think this is a very important aspect of resuming metabolic surgery. I work in All India Institute of Medical Sciences, which is the largest public hospital and the tertiary teaching center in New Delhi, India. And because of our premium institute, we are leading the national efforts in the COVID-19 fight in India. This is my case mix disclosure. We do majority of the patient sleeves, and the remaining are mix of Roux-en-Y and OAGBs. And over the last few years, it's been 50% sleeves and 50% of both the bypasses. I have no conflicts of interest to declare regarding this presentation. So let's see the challenges of resuming elective bariatric metabolic surgery. There are risks to the patients. We all know that. There are risks to bariatric surgeons and healthcare workers. As Dr. Jondal pointed out, we need to protect ourselves first. And there's a possible shortage of resources and equipment and manpower for possible second wave. Now, if you look at this slide, and we've already discussed that patients of obesity have worse outcomes should they develop COVID-19. And in this large study published in JAMA, where thousands of patients were studied, the prevalence of obesity was found to be more than 40% in the admitted patients. And again, in this study by France, if you see the BMI of more than 35 had an odds ratio of 7 for invasive mechanical ventilation, showing that obese patients, should they develop COVID-19 infection, have worse outcomes. So what is the relevance of this to our resuming bariatric and metabolic surgery? No, I share the enthusiasm of most of my speakers about resuming bariatric surgery. But we have to remember that these patients do not get thin immediately after surgery. They still remain obese in the immediate perioperative period. And all those factors which have led to worse outcomes in obese patients still remain applicable immediately after surgery. So we have to remember this fact very, very carefully. And let's look at what are the risks to the bariatric patients then. So one is obviously the risk of severe complications, hospitalization, going under the ventilator and ICU care if they were undiagnosed or asymptomatic or a pre-symptomatic carriers of COVID-19. Second is probably less talked about is increased risk of contracting the infection as a result of various physiological changes or the surgical stress itself. And we know that there are unknown perioperative variables in a truly novel and dynamic situation. And last not the least, there is a challenge of diagnosing and managing complications should they develop after surgery. This is a study from Iran in the initial phase of COVID-19 pandemic, when 4 patients who underwent bariatric surgery developed COVID-19 symptoms, and 2 of them required ICU care. Fortunately, there was no mortality in this series of 4 patients. But if you look at these 4 patients who underwent elective surgery in the early part of the pandemic era, when there was less awareness, there were 3 deaths, 2 after surgery, and 1 obese patient who had been planned died just before the planned gastric bypass. So now let's look at what are the measures to mitigate the risks. I think my previous speakers have talked about patient triaging based on individual risk factors, but I have a different take on that, and I'll come to that. Optimization of comorbidities is desirable and should be adhered to, including some amount of preoperative weight loss with very low calorie diet. We need to have an extensive patient screening. As Dr. Jondal said, that every patient has to be a COVID suspect. So we have to take a history, COVID-19 testing and imaging. And last but not the least, induction of safety measures in all SOPs involving the journey of the patient from pre-admission phase to discharge from the hospital as well as post-discharge care. So this is the recommendation from our society, the Obesity and Metabolic Surgery Society of India, which I was privileged to be a part of. And we have submitted our recommendations for publication in obesity surgery very recently. And what we believe is that the case priority for the elective cases or the non-urgent cases should be actually patients who are safe to operate first, because we have not tested our systems yet. If we are planning to resume surgery, we need to operate on patients which are likely to be discharged soon. So younger patients with few comorbidities are ideal. And in our opinion, it's initially best to avoid elderly patients, super obese patients, complex revisional bariatric operations of weight regain, or high-risk patients who have sleep apnea or history of venous thromboembolism. This is a very recent paper which I came across while I was preparing for this presentation, and this is from Dr. Ali Amanian again, where 4 centers from Ohio have divided their pool of waiting patients into 3 tiers based on individual risk factors, which are actually based on age, the BMI, the presence of comorbidities, presence of lung dysfunction. And they have suggested, like us, taking tier 1 or the lowest risk patients first, and based on those outcomes, go on to the tier 2 and then the tier 3 or the highest risk patients. And the underlying principle for this sort of management is that for tier 1 patient, we are expecting rapid discharge. And if you have tier 3 patients to be taken initially, we would have almost a nightmarish situation where we have a complication in a high BMI patient with cardiopulmonary comorbidities, which will require possible ICU care and ventilator. So this is what our society, as well as this paper, believes in, this sort of triaging. So when you're talking about reducing risk among patients as well as healthcare workers and surgeons, what are the hospital requirements? So the surgeries should be done in a COVID negative building, or if such a building or such a site is not available, in a different wing of the main hospital. All healthcare workers should work only in the COVID negative areas. They can't be working in a COVID positive area in some days and COVID negative area in other days. And they should be regularly screened for COVID-19 and should be definitely be negative. One should not resume elective surgeries until there's an adequate provision for PPEs. And all healthcare workers should be properly trained in proper donning and doffing and about the latest hospital protocols. As been pointed out, I think it's the considered use of pre-arrival screening and pre-operative patient evaluation using telemedicine that will avoid contact with the patient, and one can actually screen these patients very effectively using telemedicine protocols. I think all this history is very well known to all of us, and we should screen them for this history of contact or travel, and also for symptoms like fever, cough, and fatigue, shortness of breath, and maybe sometimes GI symptoms can also be caused due to COVID-19 disease. Let's come to patient preparation. I think communication with the patient is extremely important. They have to be well informed about the risk of getting operated during the pandemic, and they have to be motivated. As I already said, better control of comorbidities is desirable. All patients should preferably self-isolate for 2 weeks before the operation. And all investigations, including tests for COVID-19, must be complete as far as possible before admission. This is to minimize the hospital stay. So all patients should have a negative results for a COVID-19 antigen test, again, very close to the operation. So at admission, one should admit the patient as close to the date of surgery as possible to reduce the hospital stay. Admit in isolation room, allow only one attendant. Surgical mask should be used by everyone. Body temperature monitoring regularly. And a re-evaluation on the day prior to surgery by the surgical team and the consultant with special review of all the reports and COVID testing reports. As we all agree that COVID testing is mandatory and ideally should be done in view of the asymptomatic nature of these patients. But however, this will also depend on the local availability and the local national and state policies. We feel that if available, both the antibody and the reverse transcriptase PCR should be done, because antibody test has a higher sensitivity which the RT-PCR lacks. And recently some other tests have become available which provide both screening as well as diagnosis, but some sort of testing, especially in antigen testing, is required. I think imaging is a slightly controversial area. Patient transport should be avoided, kept to the minimum, and whenever required, portable radiographs should be done. An HRCT test, although the initial reports from China showed it to be a very good screening test with a very high sensitivity, there have been reports to the contrary. However, we still feel that we need to use it in either all cases or in selected cases of patients with lung dysfunction. And if at all we are doing it, we should do it as close to the surgical time as possible, preferably in the morning of the surgery or the evening before. As has already been pointed out, we need a special consent form, and this is a consent form we have prepared. It can be used by any of the bariatric surgeons, and the essential points are that the patient should be aware that they are being operated during the pandemic, that if they develop COVID-19 during their hospital stay, the hospital will not be held responsible. And I think the most importantly, that they must be aware that they would have more complications and possible mortality should they develop COVID-19 immediately after surgery, because they're not going to get thinner immediately. What about the postoperative care? It should be done in an isolation room. ERAS protocols are still applicable because they reduce the hospital stay. We feel that discharge should be discharged at home as a default pathway, not elsewhere. Anticoagulation should be taken very meticulously because we all know the risk of coagulation and the role of coagulation in COVID-19. Again, isolation or social distancing for another 2 weeks. Educate the patient to contact the surgical team immediately, not the GP, but the surgical team immediately for any suspicious symptoms or signs. And we should provide a dedicated phone number for that purpose. And for the follow-up, we should minimize the follow-up visits by using telemedicine again. Again, in the postoperative care, I think the most important part is to have a high index of suspicion and investigate promptly if the patient develops some suspicious symptoms. And this should not be neglected. Now let's talk about risk to bariatric surgeons. As you all know, it's very important to protect ourselves. And where does the risk lie? It lies from cross-transmission of the infection from patients and other healthcare workers. And we all know OR is a high-risk area where endotracheal intubation, aerosolizing procedure. Then there is an issue of virus aerosolization in surgical smoke, body fluids, and close contact with other surgeons. So what do you do? So endotracheal intubation is recommended that the team should be kept to the minimum, and they should wear some sort of PP when they're intubating the patient. And there have been special, tricks being designed to prevent the exposure to the intubating team. And one important recommendation has been to for the surgical team to wait for some time after the intubation to enter the OR. Now, this time can vary from 15 minutes to 3 minutes based on air recycle rate. This was a paper from Singapore where they said a 3-minute wait time is suggested based on a recycling rate of 25 to 30 cycles per hour. But again, I think one should look at your own OT settings, and I think some sort of waiting time would be desirable. Now let's come to the more controversial risk of virus aerosolization in surgical smoke. Now, we all know that there is no evidence at present about finding COVID-19 coronavirus in the smoke. However, other viruses like hepatitis B and papillomavirus have been demonstrated in surgical smoke. Now, what I mean to say is, if there's no evidence, what would you like to do? Would you like to throw all precautions to the wind, or would you like to take extra precautions so that we do not regret? And so we feel that absence of evidence does not mean that transmission does not or cannot occur, as we know that much is unknown about this novel coronavirus. And you can look at these two papers which are not actually about smoke, but about peritoneal fluid. One paper saying no COVID-19 detected, and another paper saying COVID-19 virus was detected at 10 times more strength in the peritoneal fluid in a patient who underwent emergency surgery for volvulus. So I think we have to be err on the side of overcaution and not just keep saying that there's no evidence. Evidence can come later. I think safety comes first for us, and evidence can wait. Containing in the same theme, personal protective equipment are mandatory. A negative screening does not mean that you can omit the use of PPE by the staff. One can do a risk assessment for appropriate use of PPE, but for the operating team and in the initial part of the pandemic, it should include the following: filtering face P3 mask or a respirator mask, eye protection by a face shield or goggles, a fluid-proof shoe cover, a fluid resistance gown, and a double gloves. And I think this should be essentially a part of the PPE. What about intraoperative measures? One should have checklists, SOPs, minimize the number of personnel. And I think in the initial phase, 2 experienced surgeons should operate to cut down on the operating time, because we are out of practice actually for the last 2-3 months. And one should avoid intraoperative endoscopy for obvious reasons. Don't rush cases. We need time to clean up the OT, donning and doffing, and also other things, checks to be performed. So don't keep your cases to a lesser number in the initially. What about the OR pressure settings? Now, this had been recommended to change the pressure inside the OT from positive to negative. However, a suitable alternative is to switch off the positive pressure 30 minutes before the induction and start 30 minutes after the patient has left the OR. So this would ensure that even if there is some aerosolization, this will not spread to the neighboring ORs or neighboring sites in the operating suite. Now, regarding control of smoke, there are some important lessons to be learned from the PIPAC surgeons. And what about is PIPAC? It's pressurized intraperitoneal aerosol chemotherapy, and where they've used standard SOPs for laparoscopy, and they have pointed that it minimizes the risk, like laminar airflow, avoiding open technique using Veris needle or optical entry for pneumoperitoneum, and use of balloon ports, which reduces the chance of dislodgement of trocar and also prevents leakage during instrument insertion. So from their experience, where they worked with chemotherapeutic agents, they pointed out that laparoscopy, if followed with standard SOPs, is pretty safe for these sort of things. Other measures which have been recommended by various societies like SAGES, EAES, and inter-society group from India is to minimize the intra-abdominal pressure. One suggestion is to use an extra 5 mm port, which can be used to continuously suck the smoke during energy usage. Or one can use a filter in the wall suction system to safely capture small amounts of smoke. One should keep the electrosurgical units at the lowest possible settings. There is limited evidence on choice of energy source. However, bipolar is found to be preferable over ultrasonic energy. Obviously, there's no strong evidence to suggest one over the other right now. And one can use smoke evacuation and filtration system, as Dr. Jindal pointed out, and which can be procured during the preparation period. And what are some of the special precautions required during bariatric surgery, like Nathanson liver retractor? If you once you put it and you notice a leak of the Nemo, you take a pursing around it and make it leak-proof. Swiftly introduce staplers and suture materials to reduce gas leaks. When the gastric calibration tube is inserted during the procedure, it should be handled with all precautions that were taken during intubation, and avoid endoscopy intraoperatively. At the end of the procedure, evacuate the gas in a controlled way completely before removing trocars to a closed system. Switch off the insufflation, aspirate using a suction device, and specimen extraction and port closure should be done only in a desufflated abdomen, only when you have completely evacuated. And the drain should be clamped till complete evacuation. Smoke evacuator devices are not mandatory, though recommended, because one of the advantages is they capture smoke close to the source of emission. So they're very effective. And particulate removal will depend on the type of filter. There are filters like charcoal filters, like ULPA, ultra low particulate filter, and other filters. And some of the machines incorporate all the 3 filters, which are probably the ideal machines. However, the limitations of these machines are they're bulky, the noise level is pretty high, they're expensive, and they're difficult to maintain. And hence, most of the centers do not routinely use these machines. But however, if one can procure these equipment, I think it's desirable. These are some of the companies which make it, and this is again a table showing various smoke evacuation systems by various companies, showing the type of filters they have and the size of the particles they filter out. So to conclude my talk, I think what we need to create is create a safe environment when we want to resume bariatric surgery. We should not be in a rush. We should wait for the local authority and other policies. Look at the curve of the kind of pandemic graph, because I think safety and patients and healthcare work is of paramount importance. We need SOPs with safety measures at every step. We need excellent OR discipline and checklists. And only simple measures for smoke control during laparoscopy can be adopted. They are required. I mean, once you adhere to these simple measures, I think the risk is minimized from the smoke. And as Dr. Alexander pointed out, I think this is a good, one of the most famous persons, Mr. Boris Johnson, the Prime Minister of UK, who developed corona, unfortunately, recently, has declared a war on obesity, gaining from his own experience. And I hope a lot of politicians across the globe take cue from this, and we have increased number of obese patients who prefer to take bariatric surgery. Thank you so much for your patient attention, and I'm open to questions. Thank you.
All right, thank you so much, Sandeep. Dr. Zindel, any comments on the talk?
Congratulations, Sandeep. A very nice presentation. I think for me, this is one of the most controversial topics. I think the initial recommendation that we should do open because it's safer was one of the mistakes that we commit, because really it's more unsafe now, we know, because in laparoscopy, thoracoscopy, you can contain the electricity fumes and all the gas inside the patient, so you can dispose it much easier. So this is a big point in favor of laparoscopy. So I think that's a good thing. I agree with the low volume, but we noticed something that it's not really data, but we are studying it now with some people from New York. Montefiore Hospital Home had more than 1,700 patients at the hospital. So we noticed the same. We noticed that if the patient with coronavirus has symptoms, you will find the virus in the peritoneal fluid, in the smoke, everywhere. But if the patient that has coronavirus with no symptoms, we couldn't find the virus. So that helped us a lot in decide what to do. So we don't change how we protect ourselves. I mean, because we always use, not the big ones, but we use some kind of glass. We use the same masks. We don't change to N95. But for a year, we've been using smoke evacuators. I think the most important thing is the smoke evacuator, low pressure. And I want to ask you something specific. For us, that we like to close our trocar hole sites, now it's become a problem because now you need to close them with the patient totally deflated, because that's the riskier part. Removing a specimen, like in the sleeve, and the second part is when you finish the case, now you're gonna close the trocar hole. So what have you been doing? And then I'll tell you what we do. What you've been doing for that?
So honestly, we at our center have still not started bariatric surgery, but what our society has deliberated and recommended is to close it obviously after desufflating the abdomen, and if we require a slight extension of the incision, increase the size of the incision to properly close the port side, because obviously that is more important than a bit of a few millimeters of increasing the incision size. So I believe yes, port should be closed only after completely desufflating the abdomen, and should be closed properly. That's what we say.
Perfect. So yes. So this is what we do, because closing the obese patients in a trocar site is not easy. When you do BMIs of 45, 50, 55, it's like in the middle of nowhere. So what we do is, as I mentioned before, smoke evacuators are very important to us. If we're gonna remove the stomach from the sleeve gastrectomy, we just bring the tip to the trocar. We don't bring the sleeve outside. Then we reduce the whole CO2. We didn't do that before. And now we take the sleeve without CO2 inside the abdomen. That's what we do. And then we finish, we put the trocar back, then we inflate again. And for the first time now we are using trocars, like, I don't know if you have them, like Troclos or some other trocars, that you put the stitches in the incision since the beginning. So when we finish, we remove again all the CO2 and we tie the sutures. So I think things are gonna change. I think that with that virus are for the future. So I think we don't need to get crazy and dress like astronauts, but we need to make sure we contain all the time the aerosolization. Thank you very much. Very nice presentation.
Thank you. Thank you.
All right, thank you so much, Sandeep and Dr. Nathan.